Good afternoon, everyone. This is Ashutosh Tyagi, hosting the webinar on patient safety and community health awareness on malaria on the behalf of Ishan Institute of Pharmacy. And today we are celebrating the World Malaria Day. And today I'm having two prominent colleagues with me, Ms. Pooja Arya and Dr. Dil Prasad Subba, share some interesting facts and useful knowledge on the particular topic. So, without wasting any time, I would like to call my colleague, Ms. Pooja Arya, to share her views and some knowledge regarding the particular topic we've organized a webinar on. Pooja ma'am. So, I
Thank you,
would like,
Ashutosh sir, for such a warm welcome. I am Pooja Arya, working as an assistant professor at Ishan Institute of Pharmacy, Greater Noida, UP. Once again, welcomes you all in today's webinar entitled Patient Safety and Community Health Awareness on Malaria, organized by Ishan Institute of Pharmacy, Greater Noida, UP. Malaria remains an important cause of illness and death in children and important cause for adult in countries in which it is endemic. Malaria control requires an integrated approach including prevention, primarily vector control, and promote treatment with effective anti-malarial agents. So firstly we will understand what is malaria. Okay. Firstly, understand what is malaria. So, malaria is an acute febrile illness caused by Plasmodium parasites, which are spread to people through the bite of infected female Anopheles mosquito. So, parasite is Plasmodium. There are 5 parasite species that cause malaria in humans. So, first is Plasmodium falciparum, second Plasmodium malariae, third Plasmodium vivax, fourth Plasmodium ovale, fifth Plasmodium knowlesi. Falciparum malaria is potential life-threatening. Patient with severe falciparum malaria may develop liver and kidney failure, convulsions, and coma. Although occasionally severe infection with Plasmodium vivax does occur, and Plasmodium ovale generally cause less serious illness, but the parasite can remain dormant in the liver for many months, causing reappearance of symptoms months or even years later. Okay, now we will understand about some sign and symptoms of malaria. So the first symptoms of malaria is fever, headache, and chills. Usually appears 10 and 15 days after the infective mosquito bites and may be mild and difficult to recognize as malaria. Left untreated, Plasmodium falciparum malaria can progress to severe illness and death within a period of 24 hours. Okay, so some population group are at considerably higher risk of contracting malaria and developing serious disease. Like first is infant, second children under 5 age, pregnant women and patients with HIV and AIDS, and as well as people with low immunity moving to areas with intense malaria transmission, such as migrant workers, mobile population, and travelers. Okay, next is some sign and symptoms. Okay, centrally it is headache and respiratory system, dry cough, stomach and nausea, vomiting. In pregnant women, this is low gestation body weight, spontaneous abortion, premature birth, stillbirth, which is death or loss of a baby before or during delivery. In liver, uh, enlargement of the liver and spleen, and skin chills and sweating. In muscular, fatigue or pain, muscle pains, and vomiting and nauseating effect are those. Now is treatment of malaria. Okay, early diagnosis and treatment of malaria reduces disease, uh, prevents deaths, and contributes to reducing transmission. Treatment of malaria depends on three factors. First is the species of malaria causing infection, second, severity of infection, and third is age of the infected individual. So, there are these three factors for treatment of malaria. So, first is species of malaria causing infection. Okay, so here are is some anti-malarial drugs. So, according to treatment of infection, there are two types: treatment of uncomplicated malaria and severe malaria. So, first is treatment of uncomplicated uh, transmitted by Plasmodium falciparum. So, firstly, the best available treatment, particularly for Plasmodium falciparum malaria, is artemisinin-based combination therapy. So, primary objective of treatment is to ensure the rapid and full elimination of Plasmodium parasite to prevent an uncomplicated case of malaria from progressive to several disease or death. So, artemisinin based combination therapy, commonly known as ACT. So, these ACT options are artemisinin plus lumefantrine and artemisinin plus amidoquinine, artemisinin plus mefloquine, artemisinin plus sulfadoxine, and pyrimethamine and dihydromethacin plus pipraquine. Second is treatment of Plasmodium falciparum in at risk group, which are children under age of 5. Okay, so for pregnant women in first trimester, quinine and clindamycin are advised. For pregnant women in second trimester and trimester, ACTs are recommended. For lactating women, ACTs are recommended apart from dapsone, tetracycline, and primaquine. Next is treatment of uncomplicated Plasmodium vivax malaria. So ACT with primaquine for chloroquine resistance infection. So there, chloroquine 25 mg base per kg body weight divided over 3 days taken with 0.25 mg base per kg body weight of primaquine, which is taken once daily for 14 days. Now, last is treatment of severe malaria. For adults, treatment with artemisinin, IM injection, and IV infusion. And for children, artemisinin, artesunate IM injection or IV infusion, quinine or artemether. Okay. Now, lastly, some risk factor for malaria. Okay, so low utilization of insecticide treated bed nets. And second is low utilization of indoor residual sprays, availability of multiple mosquito breeding sites or stagnant water sites near the home. And next is staying outdoor overnight, persons living near irrigation sites and dam areas, person who keep livestock live in near river. और ऐसे और okay. So next is here is some following are some of the home remedies that can be used for treating malaria. There are 16 home remedies to control malaria symptoms. First is cold water treatment. Cold water treatment is refers to dipping a piece of cloth in water and wrapping the body for a few minutes, or you can just cover the forehead with a piece of water soaked with cloth. Okay, so there is to lower down the temperature and fever in persons. Second is keep your surroundings hygienic. In this, you can proper drainage system for water. Third is drink lukewarm water. Uh, okay, lukewarm water is helpful for immunity boosting and detoxify our body. Uh, Next is grapefruit. Grapefruit is helpful for strong immunity and building our immunity system and low down the temperature. Next is lime and lemon. Lime and lemon is helpful to bringing down the temperature and would also treat our throat, sore throat. Next is dhatura. Dhatura is well used for treating malaria. Mix it with jaggery and have it brings down the temperature tremendously. Next is tulsi, yeah, basil leaf water. Basil leaf have a antioxidant and helps in cleansing the body. Tulsi tea is also used for treating dengue and chikungunya. Next is fever nut seeds. Fever nut seeds are commonly known as Kantkaraj, very useful for treating malaria. It is available at any herbal store and can be easily preserved. It is suggested to take 6 grams of these seeds with a cup of warm water, preferably before the onset of fever and also after the onset of fever. For better understanding, uh, use fever nuts for malaria treatment. Next is alum and fitkery. Okay, so alum is useful and beneficial for our body and for treating malaria. It should be consumed after it is dried, roast, and powdered. Half a teaspoon of alum should be taken a few hours before the expected attack of fever and again after the expected attack. It helps in bringing down the temperature. Now, I would like to call Dr. Dilpasha Subba sir for further continuation. Thank you.
कहाँ है मेरा हेलो हेलो आर यू एडेबल्स हेलो हेलो सो
Yes, sir, you are audible.
Okay, thank you, Puzaman, for inviting me. I would like to thank you all and respect it all. I'm very glad to today to all here to just little bit awareness program on this malaria. So we are try to little bit awareness in our community. So we will today try to say something about this malaria. This, how how the malaria. So how the malaria we are prevention from these. Safety from the anti-drugs, anti-malaria drugs. Okay, this one. So how we this no, how we safety from the anti-malaria drugs, because anti-malaria drugs is a uh, prevention from the severe drugs interaction. Sometimes no, sometimes it happened drugs interaction, sometimes it's medication errors, sometimes it's complications malaria, sometimes it's uncomplication malaria, contraindication and drugs interaction. It will be happen during this medication time, during the prescription time. Okay, it will be happen. So what happened basically in our society, doctors generally prescribe medicines like anti-malaria drugs, and it will be a side effects sometime ulcers, ulcer, then skin rosses, sometimes neonatal death, and sometimes pregnancy loss, okay, maternity loss, and this what basically so many causes is coming in this our body function is lost. So that's why how we are prevention from this case anti-malaria drugs, we are safety, how we make to safety from the anti-malaria drugs. So let's say, so this is the anti-malaria drugs, how we are safety from this. Okay, this is a maybe anti-malaria sequence effect of anti-malaria drugs. Basically what happened, anti-malaria drugs will be ADR, adverse drugs reaction, sometimes adverse drugs event and side effect too much high. So adverse event, this will basically will be seen in this our community. Okay, so how we are prevention from this malaria. So this I think, okay, then due to this anti-malaria drugs, uh, anti-malaria drugs basically this due to the what happened medication errors and adverse prescription error, dispensing errors, administration error, monitoring errors, communication errors, and pregnancy human, it should be very careful during this prescription medication. So during the taking the medication of this anti-malaria drugs, because anti-malaria drugs don't take easy. Okay, it's very dangerous. So also in our community, so to be we have to aware from this uh, cases. So overall outcome of symptom of malaria, we generally we see in this like fevers, 99% we often see in this case. Okay, those who are person that getting malaria, they often get this fevers like vomiting, headache, abdominal pain, and body ache, and diarrhea and nausea. This is general we often see. So and general prescription or general medication or medicine we seen in the prescript those patients get prescribed from the any healthcare professionals, doctors and nursing, anyone. So we can see there as anti-malaria drugs 100% this prescribed, antipyretic drugs and anti-helminth drugs, anti-anemic drugs, antibiotic and others. What happened, this general we seen in the prescription, but what happened suddenly drugs malaria, anti-malaria drugs interaction with this antipyretic drugs, sometimes it's interaction with antihelminths, sometimes it's anemic drugs, and sometimes antibiotic drugs. This is just contradicted each other interaction, then patient will be illness, sometimes die, sometimes what happened is a side effect, adverse effect, and so many of our body function will be lost due to this medications. Therefore we have to be very be careful, we have to so careful to take a medicines take a medication during this malaria patient at the hospital, either you stay at a home, we have to very careful take this medication. So it's very dangerous. So what happened after, so let's say this is general things, anti-malaria drugs, what happened, how we will safety from this material, this is generalized views. So chloroquine is the general we prescribe the suspected drugs of malaria, we are prescribed that drugs is a chloroquine. So chloroquine, what happened if the patient is a epilepsy there, if the person is epilepsy does contraindication, if they are chloroquine gives of overdose, what happened, they are overdose will be patient is die. So we have to be very careful this also. and Pramakune. Pramakune is basically pregnancy human, and during the spreading time, what happened? They are the maybe a chances are decrease the blood and hemolytic cases will be occurs. So and another drugs is Flamacunes, Mefloquine. Mefloquine, what happened if the person is too much depression, so much tension, okay, they like this schizophrenia. That's why it should not be given. But what happened that time if this Mefloquine is given, that time will be psychotic disorder too much, otherwise side effect will be caused. So last another things is quinine. Quinine is another drugs is a complicated malaria basically is given. So what happened during this also uh, optic neuretics, thrombocytopenia time, if they are given, so this also one of the hemolytic anemia will be caused. So another thing, halofentin is breastfeeding during this time. What happened if they are prescribed the falofentin, it will be cardiac arrest. So these drugs are very careful to we have to see during this medication time. And another drugs is a sulfadoxine and paramethamine is another drugs into the anti-malarial drugs. It's a combination drugs. What happened if this also given if the patient is renal failure, this kidney disease, if they are if the side effect will be or adverse effect too much, what happened? This skin rashes, too much skin rashes ulcer will be caused, and often we see in the mouth ulcer and skin rashes like too much overall we've seen in the mouth. This way will be caused. So another artemisinin and lumefantrine is generally giving the uncomplicated malaria. Uncomplicated method generally giving this medicine, artemether and lumefantrine in the northeast area, basically giving these drugs. But what happened? This suddenly pregnancy human severe malaria, if they are prescribed, it will be hair loss. So you cannot be hear anything from the outside. Okay, this one danger. This also anti-malaria drugs. So we have to careful. This also malaria. This anti-malaria drugs. So contraindication is very. We have to careful to look during the medication time. And last is artemether and mefloquinins is will be irregular heartbeat contraction. If the heart patient, it should not be given because it will be empty. It will be cause vomiting during the pregnancy. Also that given it also be defection the fetus. So another last is quinines, ciprofloxacin antibiotic. If the antibiotic anti-malaria give, it will be something thrombocytopenia and allergy will be generally caused. This is general things. So look at this on the glance of this oversee this efficacy of the anti-malaria drugs. Too much efficacy is that is artemisinin is one of the combination of drugs. If the combination is drugs is a too high fastest work, and ADR also it's worth too much. Because ADR is basically we see in the chloroquine is a hypertension, and quinine say this hypoglycemia, matlab diabetes patient is there, it should not be given because it will be too much low glucose level will be occurs. Then mefloquine neuropsychotic drugs, psychotic will be caused, ADR will be occurs. And last artemisinin is combination drugs, it will be given the heart disease, everything will be happen. Basically heart problem patient should not be aware from this case. So last how do administration this drug? Do not give parentally the child this chloroquine, because what happen if this given and it will be heart irregular heart retina damage will be occurs. So there's another things. And halofentin do not be give with the parentally, very restricted, because it is will be psychotic patient, it will be psychosis person will be occurs if they are giving parentally. So this is very careful. And last artemisinin it should not be given because what happened is it should not work hypnocytic stage is not work. So artemisinin is very careful should be during the administration time. The uses we generally we see in this chloroquine is a chemoprophylaxis. Generally we see in suspected malaria will generally prescribe this medicine. And uncomplicated malaria basically sulfadoxine and parametin. Basically we seen. And this severe malaria and complicated malaria we can give chloroquine is seen. This basically uses. Okay, then uncomplicated malaria we mefloquine is given. And last artemisinin is basically specific complicated too much high, that's time we will be giving this artemisinin. Artemisinin is basically a combination of drugs. So this is general things we have to care and very be careful during the time. So what happened? Anti-malarial, what happened during the on the humans during the this maternity rate and pregnancy humans trimester exposed. So this is a research. 2020 is a Myanmar is the research. Artemisinin is a and clindamycin is given. So this patient is 46 outer case, two people dead maternal stage during this time. The pregnancy human, what happened? 46 cases of pregnancy in women, artemisinin and clindamycin is given. That time, 20% in the abortion was seen, and stillbirth as fetus lost during the pregnancy. That time, well, 46 out of case 7 is the losses. So congenital abnormality out of 46, one is considered occur during this time. This is this tertiary care hospital research base. This drugs we seen. Then outer 46 at 10 is a trimester exposed is losses there. So during this all pregnancy women. So another drugs is artesunate and atovaquone and pramaquine is basically outer 142 is basically headache generals and neonatal date outer 27 one is neonatal date. It's also research on the Myanmar. So artesunate and sulfadoxamine and paramethamine is date one a maternal stage and outer 32 case 13 are basically causes this one and stillbirth 325 level are stillbirth loss of fetus during that pregnancy and umbilical hernias 1 and outer 325 cases and neonatal date 8 outer 345. This research on this tertiary care on hospital on Geneva is one of the states that but outer of view of this case we have to careful during the pregnancy human and maternal case is very careful. Anti-malarial drugs is a prescription if the anti-malarial drugs are going if they are humans during the pregnancy human trimester and this maternal state we have to very be careful because drugs interaction will be severe death and occur also so many will be other side effect will be caused. So very be careful during the maternal pet stage and pregnancy and trimester. This is a careful. So complicated and uncomplicated malaria. Basically, what happened during the if uncomplicated malaria, generally will prescribe this medicine as falciparum. This is falciparum is artemether and lumefantrine combination drugs. These are 3 days basically given. If the VVAX and chloroquine is given, and if the VVAX malaria, but it should not be give. Artesunate plus sulfaloxine and parametin because it's not active during that malaria, VVAX malaria. And the complicated malaria should not be give this artesunate and mefloquine because they are in neurotoxic stage during the that time. So and complicated generally we are prescribed the artesunate start first will start artesunate and start generally patient if are stable then with orally we are start quinine and these are basically and pramaquine is a contraindicated during the pregnancy. What happened because vomiting will be caused during the empty stomach and if they are giving empty stomach will be vomiting too much cause this is it's just complication and contraindication each other. So doxycycline is a contraindication during the pregnancy. What happened if the doxycycline giving the during the pregnancy is a fetus? There is a child bones and teeth will be defection during that time. The inside of doxycycline we can easily we can give clindamycin. Clindamycin will be provided mg adjustment dose for 7 days generally. But we have to start from this. Basically, we have to prescribe medicine during the child dose of calculation and base of metabolism, and this all we have to careful to give to patient. This anti-malarial drugs will be cause effect, side effect, so much will be occurs. So then this is WHO guidelines. What happened anti-malarial drugs? How will it prescribe during the anti-malarial drugs? So strand dose. Basically, uncomplicated, simple, mild malaria will artesunate and lumefantrine combination is first line is given orally 20 mg. Artemisinin and lumefantrine is 120 mg per tablet. So for tablet twice daily for 3 days, and artemisinin and mefloquine is basic alternative second line drugs orally given. Artemisinin 4 mg per kg and mefloquine so 20 mg per kg twice daily for 3 days. This is simple. And another thing is the drugs for complicated malaria. What happened on complicated malaria? Okay, complicated something severe malaria and cerebral malaria, something renal malaria, These are complicated malaria. So that's time artesunate with a single drugs will given, first line drugs, and IV intravenous, IM intramuscular will given. So little bit pain, but it is will be good. 2 to 4 mg will 4 mg per kg will providing. Basically, it's given 12 hours until patient is stable. Then we will start the oral medications. So quinine, second line drugs is anti-malaria drugs is IV fluid. IV is generally prescribed IV, and 20 mg basically given per kg and 8 to 12 hours until patient is stable. Then we will start oral medication. This is simple. This WHO guideline, but we have to be very careful during this medication. So over with drugs interaction, how the drugs interaction and consequence during the anti-malaria drugs and other drugs. So anti-malaria drugs interaction with antivirals, the anti-retroviral, the but what happened? They are increase the artemether and lumefantrine is we increase increase the potency. So another things, and this antifungal drugs and anti-malaria drugs, what happened? This also increase the concentration artemether and lumefantrine potency. So these are very careful during the, because if they are not seen, these are, but heart attack, it will be something renal failure, and it is a neurotoxic will be occurs. So that will be very careful. We have to look these things before with medication to give patient. Okay, the and fruits, grapefruits juice and with antimalarial drugs. What happens if the interaction will increase the viability of artemisinin? Okay, and anti-tuberculosis and antimalarial drugs decrease the level of artemether and lumefantrine. So this is and last anticonvulsant and anticonvulsant anti-malaria drugs. This also decrease the level of artemisinin and lumefantrine. This is a simple. So then how we are recommended anti-malaria drugs. So this how will, if the patient is came, how will recommended this anti-malaria drugs basically. So we have to suggest to patient very as a good advice. We have to should give advice to patient. If the patient is malaria, we have to advise the patient very carefully. Artemether and lumefantrine combination take with food, otherwise it will be occurs level of other drugs, other will be cause other drug potential will be uh, increase. Or autovacan take with the fatty food, fatty with meals, it increase the absorption, solubility absorption, its label also this. So pepperacune and take with empty stomach, because what happened if they are take the do not take empty stomach, what happened, absorption will be failed. So this is a, and if they are not taking this sequentially, heart risks will be problems and prolonged QT prolongation. Okay, this rhythm, heart rhythm will be occurs, and heart attack will be chances is come. So and another thing is a pramacune what's take with food, because it's, if we take this, absorption will be occurs, and if you not take, absorption will be decreased. It's simple logic. And another is mefloquine take with food, because what happened if they take with the food, increase the solubility absorption in generally, and this also increase the level of drugs. And doxycycline and take with food, this is a general thing. Doxycycline antibiotic basically take without food, it's stimulate, it is a decrease the absorption. This is basically treatment of anti-malaria drugs. How will take, how to avoid, how will uh, take care, how will make patient safety from the anti-malaria drugs, how will the safety from the other drugs interaction, ADR drugs, adverse event and side effect. We have to safety. We aim his safety to patient without side effect, without any causes. Okay, patient will be safety. This is a basic thing, and I hope you are all good. And thank you. You all have understand, I think. Thank you so lot. Another thing, another is, I think Asutosh sir is coming. I invite you, Asutosh sir. Thank you.
Thank you, sir. There was a very informative knowledge you have shared with us. And I would like to conduct the further process as my colleagues, Ms. Pooja Arya and Dr. Dilprasad Subba, has created a map work for you regarding the treatment regimen and the recognition of the particular disease. So I would like to further conduct it. So What is malaria? Malaria is nothing, it is just a mosquito-borne disease, parasitic infection. What it deals with, it's having four parasitic groups: the P, falciparum, vivax, ovale, and malaria. And among these four, the Plasmodium falciparum is the most lethal parasitic form, as it can introduce splenomegaly. And what is splenomegaly? It's nothing, the abnormal enlargement of the spleen. Mm. Okay, so okay, am I visible? Okay. So here I'm sharing some figure on Indian aspect. Malaria in India. Out of every seven individual in India, we have one carrier of malaria. India accounts for 70% of malaria cases and 69% of malaria deaths in the Southeast Asia region. Next, here I have discussed some cycle, parasitic cycle, malarial cycle. What does it say? It explains that once the parasite matures into a motile state, it migrates to the salivary gland of the mosquito and it gets injected into a human vein. The mosquito goes for a blood meal. Okay, initially stage has been done. Then, as the malarial saliva of mosquito entered the host body, will rush out to the hepatic cells, where the parasite infects liver cells for further maturation into C zone. And what is C zone? It is a asexual reproductive form of parasite. Then this stage allows the parasite to reproduce asexually, and the asexual reproduction carries out till 2 weeks. After 2 weeks, the parasite will multiply into thousands of cells, thousands of copies, and thousands of cells migrate to the RBC cells, surrounding RBC cells. This is when symptoms start to arise. Let me show you this. This is the point we are discussing right now, and here the symptoms starts arriving. And what are the symptoms? Have been already told my colleagues, and there's a mirroring image in the symptoms between a normal flu and a malaria, as symptoms shares the fever, chills, shaking, lower temperature. So we shouldn't, you know, prioritize or characterize it similarly to flu. Now, I would like to account one more important thing. Temperature plays a crucial role in the development of that particular disease. And I am having some facts in my hand that between temperature 17 degrees centigrade to 33 degrees centigrade, the adult Anopheles mosquito can survive up to 35 days, and which is a quite interesting time period for a mosquito to survive. Next, between the temperature of 16 degree to 35 degree, the juvenile mosquitoes are allowed to develop into adult. Next point clears that the 30 degree centigrade temperature is the optimal temperature for Plasmodium parasite to grow. So this point clearly illustrates you that 30 degrees centigrade is the favorable temperature for a particular Plasmodium parasite to grow. Temperature below 15 degree will not support the growth of Plasmodium vivax. The temperature below 20 degree will not support the growth of Plasmodium falciparum. Okay, this was the survival rate. I have explained you with the help of some temperature readings, which is being provided by me. Now, I would like to discuss some pathological scenario regarding this particular disease. I have illustrated some flow chart over here, which is being interlinked by each other. Here, as I have explained you in the last slide, that when the symptom starts, the further process starts. The Parasites start developing itself into RBCs, and after developing into RBCs, they have three paths to follow. The path one, which is very simple, they metabolize of metabolism of they hamper the metabolism of hemoglobin, which will produce the malarial parasitic pigmentation formation, which will eventually lead to the iron depletion in your blood content, which will eventually lead to anemia. And what is anemia? We are very familiar with the term anemia. It's just depletion of red blood cells in your overall blood count. When anemia is there, see, anemia is directly linked with the oxygen consumption of particular organ system, cellular system, whatever it is. If you are facing the condition of anemia, eventually will lead to anoxia. And what is anoxia? It is nothing, it is just a depletion or decrease in the amount of oxygen supplied as per the need. The anoxia then eventually lead to the shock. The first path is being cleared out. The second part, it may follow that the lysis of infected cells. Now, when the infected cells start lysing, they will eventually lead to three passages. They will enter into the cell debris where they will go to lead splenomegaly. Now, what is splenomegaly? It is nothing. It is when your parasitic RBCs got matured enough, so they will eventually start leaving the spleen. They start leaving on the basis of splenic clearance by binding to the endothelial cells, and this will promote parasitic growth in a relatively hypoxic environment. Okay. Now, yeah, I have discussed some pathogenesis regarding your particular on cellular level. Before explaining this to you, I would like to explain this particular chart. So basically, what happens when the main event when a particular parasite has been developed, survived, and multiplied in a tremendous manner that it will start leading to develop symptoms within 2 weeks. The most prominent thing which will happen is microvascular obstruction. Now, what is microvascular obstruction? It is nothing. The parasites developing within the infected RBCs, especially falciparum, erythrocyte membrane protein to the RBC's membrane functioning as a key ligand for cytoadherence. Now, what is cytoadherence? It is just basically a process where matured parasitic RBCs, matured, let me clear the point, the matured parasitic infected RBCs escape from splenic clearance by binding to endothelial cells and promoting parasite growth in a relatively hypoxic environment. Okay. Now, the key endothelial receptor in the brain is intracellular adhesion molecule 1. Recent studies have been identified endothelial protein C receptor as an important receptor in the brain that binds to a specific domain. Cytoadhesion results in sequestration of parasitic RBCs in the capillaries and postcapillary venules, causing heterogeneous blockage of the microcirculation and tissue hypoxia. And this particular point has been cleared that how they eventually lead to the microvascular obstruction. In addition to flow obstruction by sequestrated parasite RBCs, microcirculatory flow is thought to be further compromised by increased rigidity of both infected and uninfected RBCs and clumping of infected RBCs and uninfected RBCs adhering to infected RBCs. And this particular fundamental process is known as Rosette formation. Now, the direct visualization of microvascular obstruction is observed in the retina of adults and children with cerebral malaria, termed malaria retinopathy. Cerebral blood flow is not decreased in adults. Intracranial pressure is often increased in children but less so in adult patients. Indirect assessment of sequestration via estimated tool parasite biomass measured by Plasmodium falciparum. Histidine-rich protein 2 was shown to contribute to AKI in adults with severe malaria. Autopsies studies of adult and retinopathy positive children dying from cerebral malaria show prominent sequestration in the brain microvascular compared to adults with fatal non-cerebral malaria and retinopathy negative children. Postmortem studies reported sequestration of parasitized RBCs in renal glomerulation and peritubular capillaries in adults and children. Another event the parasitic RBCs would eventually lead to is endothelial activation, as it plays a crucial role in the cytoadherence of parasitic RBCs. Now, what does it explain? Microvascular obstruction induced tissue hypoxia is compounded by microvascular dysfunction and increased oxygen demand. In adults with cerebral malaria, there is endothelial and astroglial activation in the brain with variable inflammatory responses and mild functional changes to the blood-brain barrier. In children with strictly defined retinopathy, positive cerebral malaria, breakdown of endothelial barrier is observed particularly in areas of sequestrations. Pattern of histopathological changes within the brain in cerebral malaria vary between adults and children. With less inflammatory cellular infiltrates and edema in adult cases, a recent pediatric autopsy study found that HIV co-infection influences histopathology. I am repeating the point. The HIV co-infection influences the histopathology, increasing the degree of platelet and monocyte infiltration around damaged microvascula. In a recent MRI study of similarly defined children, 35% had evidence of brain swelling, most commonly in fetal cases, implicating brainstem herniation as the cause of death. Another recent serial MRI study in India included adults and children found that 50% of patients had evidences of brain swelling with posterior vasogenic edema and vascular congestion in the basal nuclei. All patients had rapid clinical improvement and radiological reversibility with hallmarks suggestive of posterior reversible encephalopathy syndrome. The exact cause of the brain swelling is yet unclear. Okay. Studies of patients with severe malaria having AKI show reduced renal cortical blood flow, increased kidney size, and endothelial changes in both glomerular and peritubular capillaries of histopathology. Cell-free hemoglobin and lipid peroxidation markers are strongly associated with AKI and renal replacement therapy requirement in adults with severe malaria. In children with severe malaria, an elevated heme to hemopaxin ratio was associated with hemoglobinuria, stage 3 AKI, and 6-month mortality rate. Now, there are some other biochemicals which plays a crucial role in the cell signaling and further processing of immune cells to counterpart their particular disease. And from that part of the end, I would like to explain the role of cytokinins as they are pro-inflammatory mediators, biomarkers. Those work as a chemical messengers for further processing in responsive and defensive mechanism of immunity system. There is an imbalance of pro-inflammatory and anti-inflammatory responses in severe malaria. The role of cytokines and chemokines in cerebral malaria has been recently reviewed. However, many of these studies are in the murine experimental cerebral malaria model, the relevance of which has been questioned. Conflicting evidence has emerged from human studies as to the association between cerebral malaria and levels of numerous cytokines such as tumors necrosis factor TNF alpha. Although cytokines or chemokines are clearly involved in the pathogenesis of malarial fever and may be associated with disease severity or cerebral malaria. It is not established that they are causes of coma. The role of cytokines and chemokines in the pathophysiology of AKI in severe malaria was recently highlighted. Plasma-soluble urokinase type plasminogen activator receptor, a marker of immune activation, was independently associated with AKI and RRT requirement. Previously, it was shown that TNF-alpha, but not interleukin IL-6 or interleukin-6 and interleukin-10 ratio, was associated with AKI, suggesting that TNF-alpha may induce localized renal tubular cell injury. And these are the biomarkers and other things which being on the cellular level could be explained the particular condition of malaria. Now I'm having some clinical findings with me as well. The clinical presentation of cerebral malaria is diffuse symmetrical encephalopathy with fever and absent or few focal neurological signs. In children, coma can rapidly develop after fever onset, means after 2 or 3 days. In adults, coma is typically gradual with increased drowsiness, confusion, obtundation, and high fevers. And these symptoms might be found within a week or 5 to within a week. Conversions are present in approximately 15% of adults and 80% of children with severe malaria. Now, the spectrum of malaria stretches from a clinically non-manifesting infection through non-life-threatening material episodes to serious life-threatening malaria with cerebral or systemic manifestation. Malaria can manifest as periodic fevers in which falciparum vivax and ovale, these parasitic groups share a duration of 48 hours and exhibit tertian fevers, whereas parasite malaria shares the 72 hours of time zone for a Quashian fever. Mild symptoms been explained with my colleagues as well priorly, and I will also explain them. Include headache, nausea, vomiting, diarrhea, etc. Asymptomatic malaria cases are seen in holoendemic areas due to semi-immunity, and there are more than 1,000 countries and territories those are infected by the particular disease. And some of the countries I would like to share the names with you, that those are affected tremendously with this parasitic infection. And the countries or territories came under to these groups are large areas like Africa, South Asia, parts of Central and South America, the Caribbean, Southeast Asia, Middle East Asia, and Oceania. Now there are some sequential activities being done by Plasmodium infected personnel. The parasitized erythrocyte shows vast uh, criteria of immature behavior or immature activity due to the cause of infected mutation affected by a plasmodium. When your erythrocyte got parasitized, it will hamper your immune activation, which will eventually may lead to nephritis, tropical splenomegaly, or TNF production could also be hampered, which will eventually lead to pulmonary edema and shock. Apart from this, when these particular RBCs, parasite RBCs, enter in your deep vessels, they hamper your microcirculation, which I have been priorly discussed with you. as they cause microvascular obstruction, which would eventually lead to coma or focal lesions if they reach in your central nervous system. And if they hamper your spleen, they will definitely hamper your glucose level. They will eventually lower down your gluconeogenesis process. Eventually, hypoglycemia is attained. Another thing, if these parasitic erythrocytes enter deeply into your gut section, they will decrease the blood flow of your gut, which eventually lead to endotoxemia and eventually shock. Now, some preventive measures, as we have gathered over here on the on the topic, patient safety and community health awareness. Now we have discussed how to diagnose a particular disease, symptomatical classification and treatment regimen, and the other pathophysiological and other aspects. Now we are here to discuss how we can prevent ourselves or our community uh, from preventing this particular disease to affect a large population. There are some basic fundamental guidelines being provided by WHO, World Health Organization, and conducted various meetings and scenarios and updations in their guidelines, so that the target of achieving or nullifying that particular disease on a world level, there's some guidelines time to time framed and updated by WHO. I would like to share a glimpse of those guidelines with you. WHO firstly introduced a meeting on 16 Feb 2021 where they have consolidated some guidelines regarding malaria. And it was the first meeting held with respect or in the concern of malaria, where the organization's current recommendation is on user-friendly online resources, and those guidelines include that evidence-based recommendations for malaria prevention, and the prevention is being carried out on the basis of two factors. The one is vector control, how can we control a vector, and another thing is prevention of chemotherapy. See, both of the criteria having different weightage and different scenarios. The one thing is how we can control vector. The prevention of vector could be attained either for the transmission, we can inhibit its further transmission, its further growth, or we can prevent it by chemotherapy as well, which will I will explain in further slides. Next is the case management, and this scenario is very important as it includes the diagnosis and treatment regimen. When the case is particularly been diagnosed on which particular parasitic infection the particular patient has acquired, or particular age group, or whatever particular hygiene or background issues, but complete classification of a patient should be required for diagnosis and treatment purposes. And for diagnosis, we have some processes which I would like to share with you. On the basis of diagnosis, we have five criteria to diagnose this particular disease. The first one is parasitological, the another one is molecular, the third one is antigen, and the fourth one is antibody. Togetherly, the antigen and antibody classification or diagnosis method. Now, how we parasitologically diagnose this particular disease? On last decade, the staining of thick and thin blood films was the gold standard for malaria diagnosis, which has been now in recent time is been counterpart or been replaced by RT-PCR method, as PCR-based methods detect the 50 parasites per ml of whole blood. This is approx 200 times lower than the detection limit of well-trained and experienced microscopists. Blood smear should be prepared on admission of the patient if there is no pattern of intermittent fever. Both thick and thin blood smears should be prepared. At least 200 to 300 oil immersion fields should be examined. Gamsa is the stain of the choice for blood parasite. Note: malaria parasite may be missed using automated differential instrument. Now, another factor for diagnosis of malarial vectors is molecular pattern. Different formats of PCR assays, conventional or real-time, have been developed allowing the confirmation of uncertain parasitological species determination, the efficient detection of mixed infection, or the detection of drug resistance markers. In addition, molecular methods allow the genotyping of Plasmodium strains. Recently, a quantitative real-time nucleic acid sequence-based amplification technique has been developed. This technique detects parasite RNA, which is reversibly transcribed to cDNA. The sensitivity of qT-NASBA is much faster, results in 4 instead of 16 hours. Compared to microscopy, the sensitivity is approximately 1,000 times higher. Another diagnostic method is antigen. Many commercially available rapid diagnostic tests detect histidine-rich protein 2 (HRP2) or parasite-specific lactate dehydrogenase by immunochromatographical procedures in whole blood sample. Last but not the least, antibody diagnostic method. The detection of anti-malarial serum antibodies is not adequate to diagnose an early acute infection. During the first febrile episode, no antibodies are detectable in most cases. Indications for serological investigation are restricted, and which includes to diagnose relapse of Plasmodium vivax and Plasmodium ovale, to diagnose persistent malaria in persons returning with uncertain diagnosis from endemic areas. The most widely used serological test is IFA with Plasmodium falciparum parasite from culture. Homemade ELISA tests with crude or recombinant antigens have also been developed. Now, the first meeting explains this particular points on which was held on 16 Feb 2021, conducted by WHO. The next amendment was held on 13 July 2021, where WHO provides the update to vector control guidance. The next amendment held on 18 Feb 2022, where WHO recommended for malaria vaccines for the very first time. On 31st March 2021, updated revision to the vector control guidelines was amended on this date. Particular date. Now, as I have been discussed the pathophysiological scenario, the prevention scenario, and the diagnosis scenario, along with the guidelines of WHO, I would like to explain some further points on prevention and control, and which is very most important part to counterpart this particular disease. The basic and most simpler thing in community we can explain to people, those having minimal knowledge regarding this particular disease and prevention scenario, is We should run some campaigns, or information leaflet should be printed, so which provides the prevention measurements, like when we sleep in our homes or outside our homes, we should use insecticide treated mosquito nets. For inside purposes, we should use residual spraying of insecticides. And the houses, those are sharing infants or pregnant women. The preventive therapies for pregnant women and children and infants should be carried out priorly on regular basis. Apart from these, basic functional things could also be incorporated to prevent malaria, and which include using mosquito repellent lotion, drain the water reservoir regularly, close the water reservoir, purify the good things, using mosquito repellent spray to spray the bedroom as well, using a bath net that has been smeared with insecticide, consumption of anti-malarial drugs like chloroquine every week, 300 per mg. We should also incorporate the use of full sleeves and light colored dresses. Thank you, and that was my part, and I'm very glad and very thankful to the audience for your patience and your important time. Thank you. This is Ashutosh on behalf of Ishan Institute of Pharmacy. Thank you very much. Have a good time. So.